Thank you, chairpersons. And after that excellent disposition by Dr. Sanjay Bhattad on a very important topic, I'll be dealing with something which is much more mundane, but which is very relevant in our day-to-day practice. Now, we all know that we are standing on a historical year. This is the centenary of the discovery of insulin. 100 years ago, when Banting and Best injected insulin, they wrote that they injected something of a thick brown muck. So they themselves possibly were not very pleased with how the initial insulin was looking like. From the thick brown muck over the last 100 years, it has been a long journey, but a successful one where today insulin in a vial can truly be said to be magic in a bottle because it has transformed millions of lives directly and indirectly. But interestingly, over the last 100 years, if we look at the journey of insulin, the first quarter of this century, that is nearly the first 25 years, all insulin that was available was only short-acting insulin. There was no intermediate-acting insulin. There was no long-acting insulin. So the story of basal insulin actually begins only 75 years ago, not 100 years ago. And we'll have a look at how over the last 75 years, basal insulin has changed and has changed for the better to make our patient's life even more easier. Now, this is something which we discuss on a day-to-day basis, and we know that type 2 diabetes is a condition where you have insulin resistance right from the beginning, which stays as it is throughout the life of an individual, on top of which there is progressive beta cell dysfunction. And because of this progressive beta cell dysfunction, over a period of time, at a certain point in an individual lifetime, you reach a tipping point after which there is absolute insulin deficiency. So at this point of time, you need to give insulin, exogenous insulin, in order to maintain good glucose control. And when we talk of exogenous insulin, we often try to mimic the natural insulin secretion of an individual in order to maintain good glucose control. And in an individual, the natural insulin secretion occurs steadily over time, particularly in the interprandial period, overnight period, which is what is called the basal insulin. On top of that, you get certain peaks of postprandial insulin in response to increase in postprandial glucose. So today we'll be limiting ourselves to the basal part of the story. And if you look at studies in individuals with diabetes, basal insulin requirement is about 40 to 50% of the total daily insulin requirement. And as we often say, unless you get the basics correct first, you cannot go into more advanced management. It's the same with diabetes. Unless you bring the baseline under control, you take care of basal insulin well, you cannot put a patient under good glycemic control. Now, as we said, the story of basal insulin began actually much later after the discovery of insulin. In 1936, it was for the first time that Hans Christian Hagedorn, who incidentally happens to be one of the co-founders of Novo Nordisk, he discovered that addition of protamine, which was a basic protein obtained from the semen of the river trout, it could prolong the action of insulin. But it was not 1936, but only in 1946, about 10 years later, that is about 25 years from the first discovery of insulin, that NPH, insulin on neutral protamine hagedorn, was first launched in the market. In 1952, lente insulin, which used zinc for protraction of action, was launched. But as of now, at present, lente insulin is available only for veterinary use, whereas NPH insulin is available commercially. It's manufactured by a number of companies, and it does have some role in the management of diabetes even today. I say some role, but not a huge role, because it has its own drawbacks. We know that NPH insulin does not give a 24-hour coverage. So in order to get a 24-hour coverage, you need to inject it at least twice daily. It is present in a suspension, so you need to reconstitute the insulin before administration. So unless you know how to reconstitute it well, your insulin might have a lot of variability. Even otherwise, NPH insulin shows a lot of day-to-day variability, because of which it often becomes a bit difficult to titrate properly. And of course, there's the greater risk of hypoglycemia, particularly nocturnal hypoglycemia with NPH insulin. But having said that, having spoken about the drawbacks of NPH insulin, we need to keep in mind that in patients who cannot afford the more expensive newer generation insulin, NPH insulin can still be used judiciously to give them economic basal insulin coverage. But as I said, we need to move forward. And by moving forward, we actually move forward nearly 50 years. The year 2000 saw the launch of insulin Glargine, which was human insulin, which was modified in certain amino acid positions to give you an insulin which had a longer duration of action. And how was its action protracted? It was synthesized in a manner so that it would remain in solution in an acidic medium, in an acidic solution. But once it was injected and it reached the body's neutral to mildly alkaline pH, it would be deposited in the form of small crystals from which monomeric insulin would gradually diffuse into the circulation. Now, interestingly, since it is present in solution in an acidic medium, I think some of you might get your patients reporting that when I inject insulin Glargine, for the first few minutes, there's a sharp stinging sensation or a burning sensation at the site of insulin injection. But this is how its mechanism of action is prolonged. The other insulin which came 5 years later in 2005 was insulin detemir, where not only was the primary structure of insulin altered by substituting amino acids, but a fatty acid chain was now added to insulin to protract its action in a different method. Now, when insulin detemir is injected, it initially stays in the form of dihexamers, as zinc, which is present, dissociates with a half-life of 2 to 3 hours. The dihexamers start gradually dissociating. Ultimately, the monomeric insulin which enters the circulation, because of the fatty acid side chain, it binds to albumin, which results in further protraction of action. And it has been seen that both in type 1 as well as type 2 diabetes, insulin Glargine, as well as insulin detemir gives you equivalent good glycemic control with a much lower risk of hypoglycemia, particularly nocturnal hypoglycemia. So you get equivalent glucose control with Glargine and detemir compared to injection NPH, but it comes at the convenience of less pricks and it comes at the convenience of a lower risk of hypoglycemia. Along with the lower risk of hypoglycemia, the variability is something which is better when we consider these newer insulins, that is insulin Glargine and insulin detemir. Now, variability refers to the fact that after injecting the same amount of insulin, its action could differ from one day to other. The amount of insulin that is there in the system to reduce blood glucose could vary from one day to another and even within a day. Now, this is important because it helps us titrate dose. For example, if you inject 10 units of insulin on a given day and you get, say, 60 milligram per deciliter of blood glucose reduction, on a second day, injecting 10 units gives you, say, 80 milligrams per deciliter blood glucose reduction if there's a lot of variability. So more variability in the action of insulin translates into difficulty in maintaining or titrating the dose of insulin because things get chaotic. Your normal arithmetic fails when there is a lot of variability. In this respect, again, Glargine and particularly detemir were better compared to NPH insulin, was so that not only was there lesser hypoglycemia and lesser pricks necessary with these newer insulins, but it was also easy to titrate the dose and maintain a certain dose of insulin. But again, even with this first generation analogs, there were some drawbacks. For example, these insulins were not truly once daily insulin. Glargine was nearly once daily, whereas detemir was somewhat less than once daily. It acted for around 18 to 20 hours. So that in someone with type 1 diabetes or someone with advanced type 2 diabetes, where the beta cells were practically non-existent, there was a loss of effect at the end of dose interval. Moreover, these insulins still had some variability, although lower than NPH insulin. They were not truly peakless. There was a slight peak some time after administration. And these insulins were quite inflexible in terms of the fact that they needed to be given at a particular time of the clock every day. You couldn't precede the time, or you couldn't postpone the time of administration in a certain day's period. So now came the even more advanced Glargine U300 and the degludec insulin, which will form my discussion over the next 5 minutes. So the degludec was the second generation insulin analog which preceded the advent of U300 Glargine. This was the first of the second generation analogs to be launched. And it was sort of, you could say, a modified version of detemir, where there were some substitutions in the amino acid structure, in the amino acids of the insulin, as well as there was a fatty acid chain which was tagged along with insulin. So that when it was injected, it was initially present in the form of a dihexamer. As phenol dissociated away from the insulin, it formed multi-hexamers, they tagged together. As zinc dissociated away, the multi-hexamers started dissociating into hexamers, dihexamers, and monomers, dimers and monomers. And once the monomers entered the capillaries, they tagged along with albumin to give further protraction of action. And we know that with insulin degludec, it's a truly once daily insulin where you need not worry about an end of dose effect. Now, how was insulin degludec, the second generation analog, different from insulin glargine, the first generation analog? So we have a host of studies, right from phase 3 trials to cardiovascular outcome trials to real world evidence, where degludec was compared head to head with insulin glargine, which comprehensively shows that this newer second generation analog has a lower risk of causing hypoglycemia, a lower risk of causing nocturnal hypoglycemia, specifically more compared to U100 glargine. So this was a distinct advantage. Efficacy in these controlled trials was more or less similar, but safety in terms of causing less overall and nocturnal hypoglycemia, as well as severe hypoglycemia, was an advantage. And this difference in the rates of hypoglycemia were particularly noted at lower HbA1c levels, so that if you had a HbA1c of say around 8 or 8.5, the degree of difference in hypoglycemia between U100 glargine and degludec was not that evident. But particularly in type 2 diabetes, as you reached closer to your target of say 7 or 6.5 HbA1c, the amount of hypoglycemia that started happening with U100 glargine was much, much more compared to the hypoglycemia seen with degludec. Again, the message is not that degludec does not cause hypoglycemia. All insulins that are available today cause hypoglycemia. But the message here was that if you wanted to reach a really good HbA1c level, say 7 or 6.5, your risk of causing hypoglycemia was much higher with insulin glargine compared to insulin degludec. And just as there was a difference in variability between the NPH and first generation analogs, there was a big difference in variability between insulin degludec and glargine. And again, as I said, variability leads to less predictability. If you need predictable, sure insulin action, you need an insulin which is less variable in action, as degludec was here less variable than glargine. Possibly because of this lower variability, it translated into better time in range. So this was a trial in type 1 diabetes called the hypodeg trial, where when degludec was compared with glargine using an ambulatory glucose profile method, there was better time in range with degludec, lower variability with degludec compared to glargine, and it was primarily driven by lower nocturnal glycemic variability. Was another trial called the Switch Pro trial, where patients were switched between glargine and degludec, U100 glargine and degludec, and it was found that if you were put on degludec, you had 20 minutes greater time in range per day compared to being put on U100 glargine. And out of this 20 minutes, 12 minutes were nocturnal time in range more with degludec compared to glargine. Now, 20 minutes per day might not sound something huge, but then again, if you consider that during those 20 minutes, there could be a few minutes spent in hypoglycemia, the significance becomes even more, because even a single minute spent in severe hypoglycemia could have fatal and morbid consequences for a given individual. Now we move over to U300 Glargine. Now in U300 Glargine, there was no chemistry or biochemistry involved. There was physics involved in protracting its action. By making more concentrated Glargine, 300 units of Glargine were packed into 1 ml of the liquid. The surface area of the insulin crystals became even smaller. And as in Glargine, the mechanism of protraction is formation of crystals and diffusion of insulin from the crystals. With more concentrated insulin and smaller crystal surface area, there was lesser surface area for insulin to dissociate, thereby prolonging its mechanism of action. And as with degludec, there were trials where U300 Glargine was compared with U100 Glargine. Mostly glucose control was similar between these two, and the benefits that were mainly seen was, as with degludec, with regard to lesser hypoglycemia with U300 Glargine compared to U100 Glargine. Now, if you look at the time in range value with these two insulins, because these are the latest, the second generation analogues, degludec on one hand and U300 Glargine on the other hand, you'll find that there's not much to choose between them. They are, both of them almost have a flat profile of action, and both of them give you good time in range. In terms of numbers in this study, degludec seemed to have a few more minutes better or a few more time better in time in range, but there was no statistical significant difference between the two. However, there were two trials which showed sort of a small clinical difference between U300 Glargine and injection degludec. One of which was the BRIGHT trial, which looked at insulin naive individuals and initiation of U300 Glargine on one hand and degludec on the other hand. The primary outcome of this study was change in HbA1c levels. And with both these insulins, the HbA1c reduction was similar, so that in terms of efficacy, they were similar. There was a safety endpoint which looked at overall hypoglycemia and hypoglycemia during the initial 12 weeks of up titration or down titration phase. It was found that overall hypoglycemia was similar, but during the titration phase, hypoglycemia was somewhat lower with injection U300 Glargine compared to injection degludec. However, we need to put out the caveat here that one, hypoglycemia was not the primary outcome of this trial. The primary outcome was efficacy, which was similar between the two insulins. And the second was the number of events occurring were very low, so that it's difficult to say with robustness, with certainty, that there was actually a clinically significant difference in hypoglycemia between U300 Glargine and degludec. We come to another trial. In this trial, it was degludec which sort of showed an upper hand. This was a conclude trial where the primary endpoint was overall symptomatic hypoglycemia. Again, in statistical terms, there was no difference in overall symptomatic hypoglycemia between degludec and U300 Glargine, although the numbers were tilted somewhat in favor of degludec. So the secondary endpoints became exploratory endpoints, and looking at those exploratory endpoints, nocturnal symptomatic hypoglycemia and severe hypoglycemia seem to have a statistically significant reduction with degludec compared to U300 Glargine. So there are two different studies, one which shows somewhat lower hypos with U300 Glargine during the titration phase. This, however, was a study which was in patients already on a different basal insulin, and in this study there was lower hypoglycemia with degludec compared to U300 Glargine. But I think that there's very little actually to choose between these two. They are very closely matched, except for the fact that there is a distinct advantage of flexibility when you are using degludec, because the flex trials have shown that degludec can be dosed as close as 8 hours and as late as 40 hours without any increase in hypoglycemia and without any loss of efficacy. Whereas U300 Glargine has a flexibility of only around 3 hours. It means that if you are, for example, on a morning dose of degludec, and if you miss the morning dose of degludec, the next morning you can take it in the afternoon, the evening, or even at bedtime without any loss of efficacy. And in individuals who have a busy lifestyle, who might be traveling, This flexibility of degludec is what gives it a distinct upper hand over that of glargine. Now, we spoke of studies which showed that if you shift to one of the newer insulins, you get lower hypoglycemia, but you don't get better glucose control. However, real-world evidence suggests that if you shift to these newer insulins, you might even get better glucose control. I think the logic behind this lies in the fact that if a physician knows that he's using an insulin or she's using an insulin which carries a lower risk of hypoglycemia, it emboldens the physician to up-titrate a bit more aggressively to reach lower HbA1c levels better without increasing the risk of hypoglycemia. So although in controlled trials, the efficacy is similar, in a real-world setting with these newer analogs, it emboldens the physician to attain better glucose control. So I think the journey so far has been exciting. From NPH insulin to first generation in analogs to the second generation analogs, we have improved insulins in terms of, particularly in terms of having lower risk of hypoglycemia. But I think that the future is equally exciting. Last year, towards the end of last year, we had this publication where insulin icodec was shown to have a similar efficacy to U300 glargine. Now, what exactly is insulin icodec? It's a further modification of, you could say, insulin detemir or insulin degludec, which turns insulin into a once weekly insulin. So just like, say, a once weekly GLP-1 receptor agonist, you now have a once weekly basal insulin. We have to wait for some more time before it's commercially available, but the trial does show that it's as good in lowering glucose and as good a safety profile as once daily U300 glargine. I think the future lies in front of us. It might be even more exciting. We might have insulins as shown in the lower right panel, which have insulin tagged to the Fc portion of immunoglobulin, just like dulaglutide, which prolongs its duration of action to a week or so, and animal trials have shown promising results. Or if you look at the left upper panel, we might have an even more exciting insulin, the so-called smart insulin, which has sort of a switch on mechanism if you have high blood glucose and switch off mechanism if you have low blood glucose. So it acts intelligently to monitor, to target good blood glucose control. I think the journey so far has been exciting. The future looks even more exciting. We have a bouquet of insulins with us, each with their advantages and disadvantages, and we need to keep all the pros and cons in mind before deciding on which insulin to choose for our patient. With that, I end and I hand it back to the organizers.
Thank you, Dr. Saumik, for this elaborate talk.